Our final speaker for today is Dr. David Howell. The goal of his research is to identify and utilize clinically feasible tools which can accurately monitor the effects of concussion on physiologic function. Through the use of innovative testing methods, he seeks to combine various laboratory-based protocols which can be adapted in the clinical setting with widespread and ubiquitous use, particularly for athletic trainers who acutely manage concussions. Previously, he has studied the way that gait stability is altered following concussion, the time course of recovery of balance control under divided attention conditions, and potential factors which may affect how an individual recovers from concussion. By utilizing physiologically based assessments of function in the clinical setting, he hopes to identify cost-effective and objective tools that may be made available to clinicians in order to improve diagnosis, management, and treatment protocols. Through his varied line of research expertise, which includes neurophysiological, biomechanical, and attentional examinations, he seeks to provide evidence about the effects of concussions relevant to the fields of biomechanics, cognitive neuroscience, and clinical sports medicine. Currently, as a postdoctoral research fellow at Boston Children's Hospital and the McKaylee Center for Sports Injury Prevention, his research activities examine ways that sports medicine physicians and certified athletic trainers can accurately identify the course of full healing of the brain after concussion and the elements which may be responsible for prolonged recovery. Dr. Howell.
Those things are always way longer when somebody's reading them out loud, so I apologize for that lengthy introduction. I'm David Howell, and I'm thrilled to be here. Thanks to Precision for putting this on. I work, as Tom mentioned, about 5 minutes down the street, primarily at the Boston Children's at Waltham is where my main office is. This is a pretty easy opportunity for me to come and talk. I didn't have to come nearly as far as Tom, so he wins the award for coming the furthest. And really, I kind of want to transition from the kind of what we've talked about from the overarching kind of policy positions, moving on to the acute treatment and rest. And now, what sorts of things can we do as athletic trainers in the there we go. All right. In the acute and prolonged recovery phases. Again, as Tom mentioned, I'm coming from a perspective of kind of the more severe cases of concussion. Most of the kids that we see at our clinic are referred to us. We're kind of a tertiary specialty care center. I don't know if any of you have referred people to Boston Children's in our sport concussion clinic. But I'm going to kind of examine some of those things, and I'll get into that in a second. This is the first time I've ever put my email and Twitter handle up before my talk, so I don't know how it's going to go. If I finish my talk and I have a lot of angry tweets and emails and things like that, I know not to do it, but feel free to both ask questions to me if you think of something later. Also, if you have any questions, I think we've got plenty of time throughout. If something pops into your head, or I know online as well, wherever the camera is, hi to everybody online. Feel free to pop a question off. In the interest of full disclosure, I don't really have anything related to the topic today. I have a couple of research grants right now. One is an industry grant through Cincinnati Children's with an EEG company called Elminda, and also a foundation grant from the Eastern Athletic Trainers Association that is active. So we're going to talk about 3 things today, I hope, among many, specifically in this hour that we have together. Number 1, we're going to talk about gait and posture and the assessments that can be done as athletic trainers, what's currently available to you, an athletic trainer. Again, my background is an athletic trainer. I'm an ATC as well. I kind of come from that perspective. I'm full-time research now. I don't actively see or treat patients, just so that you know, but I am fully aware of those things that you can use, and hopefully we can kind of discuss some new ways, new things, new ideas that people can have. Second, we're going to talk about how technology might be able to improve the assessment of gait and posture. So a lot of the kind of inherent limitations to our postural control assessments have to do with the lack of objectivity. I'm a firm believer in objective continuous variables as outcome measures because, as Tom was kind of pointing at, very few things in life are dichotomous. I'm a firm believer that life is both a bell curve and it is a continuous outcome variable, meaning most things lie on a continuum somewhere. There's a spectrum, both if you want to talk about severity, degree of dysfunction, and these are really hard things to quantify. Speaking of the Berlin meeting that we were at a couple weeks ago, from which this, I don't know, there will be a SCAT4 and another paper that gives all these recommendations and things like that. The first topic that came up was, what is a concussion? And I would argue that that's probably one of the more contentious debates that was present at this meeting. So there are 400 concussion experts in a room, and the topic of CTE is a little controversial. That got a little heated. But apart from that, defining what a concussion is, what the gold standard is, and how we truly say, did somebody or did somebody not have a concussion, was very contentious. And I think that that's a lot of the problem in the research right now, is that different research groups are operating under different research definitions for what is a concussion. And that's contributed to the lack of kind of ubiquity and the lack of consistent findings throughout the literature. So again, I think the more that we can use objective measurements, especially related to technology, we're going to be able to hone in on what it is that comprises a concussion. What is the entity of a concussion? And then finally, we'll talk about kind of how gait and postural control evaluations fit into the multifaceted approach to concussion management, which is something we've all kind of heard. There's this multifaceted approach, but what does that mean, and how does gait and posture specifically fit into that? So let's get started with the current available techniques to assess concussion. So I like this picture. I'm sure this gentleman on the left doesn't love it, but it is a good representation of kind of what we traditionally think of with a concussion. We think of this a biomechanical force that induces rotational acceleration to the brain as it sits within the skull. As Christine says, we have axonal shearing and some sort of dysfunction. And I think we can all at least get on the same page with that dysfunction occurs following a concussion. And it's kind of operationally defined right now as an induced alteration of mental status. That's how the athletic training position statement goes. May or may not involve loss of consciousness. But one snippet from that is that it can affect a lot of different structures of the brain and their associated function. So let me see if I can, which one is it? This one? Nope. Middle one. All right. There we go. All right. So we've got a concussion that occurs, right? And let's say that we're assuming that it's going to affect some sort of cortical structure, whether that's microstructural, structural, but not evident on CT or MRI, which is typically the case, or functional, however you want to define that. We see that perhaps the frontal, temporal, and parietal lobes may or may not be affected by a concussion. And as a result of that, we have changes or alterations or deficits to cognition, to memory, and to what we term complex functioning. So the parietal lobe is really an integrative part of the brain where a lot of different things occur. Hard to parse one thing out. But at the same time, we kind of overlook these subcortical structures and they're oftentimes autoregulatory functions. So the hypothalamus alone controls a lot of different parts of the brain: thermoregulation, blood pressure control, sleep, sexual function, diabetes insipidus. Those are all things that are perhaps affected by concussion, and particularly the location of the hypothalamus in the brain. It sits right in the middle, and if you remember back to anatomy, it sits in that little sella turcica of the cranium. So you've got this little stalk coming down, and you've got these traumatic forces. It's at a pretty vulnerable region. And again, I'm not going to get into this today, but I just want to kind of highlight that a lot of these subcortical structures are often overlooked, much more from the physiologic perspective because they are hard to quantify, but something not to forget about. And then we've also got trigeminal or basal ganglia problems and cerebellum problems, specifically to balance and posture. One thing that's not included in here, and I'll also include it on the next slide, is that there's no mention of vision here. And it depends on the source that you're looking at, but approximately 60% of our brain is devoted to vision in one way or another. And humans are highly visual creatures. So if you hurt the brain of a human, you would expect severe visual deficits, but oftentimes they're probably subtle. And vision controls and drives a lot of other processes. And we'll talk about that a little bit later and how it relates to gait and posture. But that's something that is not purposely left out. I adapted this from a different component. But you compare that to, for example, a salmon brain, right? A fish that is about 90% smell, right? So again, if you were to concuss a salmon, which I'm not really sure how that would work, but if you were to concuss a salmon, you would expect severe olfactory deficits because most of its brain is in some way devoted to smell, and that's evolutionarily how they have thrived, right? So again, I paint this picture, but it is not fully encompassing. It's kind of the main point that I'm going to try to demonstrate here today. And I really want to focus on two things, primarily balance and posture, as you may have expected given my line of research, but also how that interacts with cognition and how those two things interplay may be an effective way for us as clinicians to truly evaluate a more integrated approach to multiple systems. And when combined, we may be able to gain new insights into how somebody's recovering, perhaps how long it's going to take them to recover, or if their brain has truly physiologically recovered or not. So we'll move on to symptoms. We've talked quite a bit about symptoms today, and I think symptoms are really important from the perspective that you want the patient to feel better, right? That I don't want to downplay that. However, if you look at these symptom domains, you can kind of tell there's a pretty heavy neuropsychologic, I don't know how you want to say it. Neuropsychologists are the ones that primarily contributed to the post-concussion scale, right? Symptom scale, the PCSS. So 2 of the 4 are very cognitive related. And I think that concussion can affect that. But we also overlook, again, some of the other basic symptoms like vision, where we've got visual problems, maybe light sensitivity. There are other symptom scales that are available that we're looking into right now that might be better at encompassing how vision is affected after a concussion, but that also may interplay into other systems, as I mentioned before. By classifying this into domains, I think that we can kind of, I hesitate to say the word subtype because I don't think we're quite there, and that's there's certain groups that are really pushing that. But I think that not all concussions are the same, as we all kind of know, and as Christine said as well. However, if we can identify the different areas of dysfunction earlier on in the course of treatment after concussion, perhaps we may be able to hone in on a more accurate treatment. So for example, if we have a universal approach, as Tom said, of complete rest until asymptomatic, if everybody's given that prescription, again, based on the athlete's history, their position at the time of injury, both the direction and the magnitude of the hit, their underlying personal characteristics, all of those things play into how they're going to report after their concussion. And again, we're kind of assuming that they're going to tell the truth, which is kind of, again, very much may not be true. However, I want to paint the picture that symptoms are good and, good to assess. They're not good. We don't want people to have symptoms. But how we go about treating those and resolving those is going to vary from athlete to athlete. The other thing is that I want to really stress is that the post-concussion symptom scale is incredibly non-specific, right? So in full disclosure, last week I was in Anaheim, California, and I was giving a talk. There's about a few more people than this, maybe a couple hundred or 1,000 people in the room. And I woke up that morning and I started vomiting. And then I got up on stage and I felt drowsy. I had some cognitive slowing. I felt nauseated. And I got very lightheaded to the point where people said, you should probably sit down to give the rest of your talk. I almost fainted. You know when you get that like vision kind of closing in on you? I think we've all experienced that. For me, that was probably the first time I've ever done that in front of that many people. But it goes to show that I was experiencing many signs of a concussion that I probably weren't related to a concussion. I probably caught a bug somewhere along the travel or something like that maybe. However, a lot of us in here as well are probably, maybe just because it's Sunday, feeling a little cognitively slow. Maybe you're feeling a little bit nervous about something, maybe the state of our country. Maybe you're feeling a little bit irritated that I made a joke about politics during this talk. Again, that doesn't mean that you are experiencing concussion. Obviously, the head trauma piece is a key element to a concussion. But these signs and symptoms are not specific to concussion. So we need to be aware of that when we're assessing that. The difficulty with tracking recovery using symptoms, and I'm getting to something here, I promise. It's really difficult to distinguish what is true recovery versus what is day-to-day variability that it's influenced by other things, especially for those of you that are in high school settings, for example. What we've seen in our clinic is the junior year of high school alone is enough to predispose people to symptoms because SATs, and they're worried about college, they're worried about their social standing, they're worried about prom, they're also worried about their sports that they're playing, but there are so many other factors outside of sports. And again, in the sports medicine research world, we oftentimes forget about that sociological component, and something that I don't want to dismiss. So these are all, again, very, very subjective. But let's look at some specific overt examples of deficits. So the video will get clearer here in a second. As Tom mentioned, this is Wisconsin, Alabama. I think this was last year. And number 2, Derrick Henry, he went on to win the Heisman Trophy that year. He's like 6'4", 250 pounds, runs a 4.440. And if we talk about force equals mass times acceleration, what you see is he's running, and he comes through with his thigh as number 7 for Wisconsin in white, comes in with his head and tries to tackle him. And so he was on the unfortunate end of a blow to the head that resulted in some sort of mental status alteration, right? So this is what resulted of this. Number 7 is playing for Wisconsin, and I want you to see where he's lining up. If you're not familiar with football, the red team should be on one side, and the white team should be on the other side. And I really like number 74, talking about Christine's, recognition. He's doing a good job of recognizing a concussion. He at least points at him, and then he goes back to the play because he doesn't want to get called out by his coach, right? So again, this is an overt example of a concussion. Luckily, in this situation, I know some of the medical staff from Wisconsin. They removed him. He did not return to play. Everything was done perfectly. We all know that is not maybe the most common. This is kind of an easy recognition, right? But a lot of times it's a lot more subtle. He might have lined up on the right side, given where he was standing at the time of the injury, and he might have been able to move around and play for a few more plays. And a lot of the kind of initial research, as a side note, there's a little bit of evidence to support that the longer you play after a concussion, if you try to tough through it, you're actually more likely to have a prolonged recovery. So, and I can provide the references if you have a question about that. But something to stress to your athletes, again, there's that education piece that those who try to tough it out, quote unquote, oftentimes take longer to just get back to the field. So again, this is a cognitive deficit. You may have a little instability there. But let's look at a physical deficit here. So this is an Eagles linebacker. And unfortunately, you'll see the hit here in a second, but he clearly has some sort of physical deficit where he's going to come in here. You see his head, gets hit by maybe a thigh or something like that. And what he's going to try to do is just stand up, right? And unfortunately, he's probably got some severe vestibular dysfunction, but this is what I would call a physical deficit. You look at his feet, where he places them. It's not normal for him. He's probably gotten hit thousands of times before and walked off the field no problem. This is, again, a very overt deficit after a concussion. So these are things that we can pretty easily recognize, but we have developed some tools and tests to be able to do this or assess this in person. So this is our initial evaluation. This is Big Poppy's initial evaluation. And he's clearly a qualified expert to diagnose, recognize, and remove from concussion. I think that catcher got a foul tip to the head, and he is being assessed by his athletic trainer, but Big Poppy is having a good time as well. So what sorts of things do we have that are available? So we have the standardized or the sport concussion assessment tool, version 3. Like I said, there's probably going to be a version 4 that comes out. You're going to have to redo all of your protocols and things like that. Say what you, make what you want out of that. But again, this was at least a good start where we wanted people to be standardized in their approach to assessing concussion. A lot of the parts of this are good because they are practical, right? As athletic trainers, you can take the scat and you can administer it to your athlete on the sideline, in the locker room, preseason, whatever your protocol dictates, whatever you've devised in your setting. And a lot of these probably you don't use. I don't know, if you use the Maddox questions or the Glasgow-Coma scale, you're probably doing them maybe initially to be thorough. But this tool was devised for immediate recognition and removal. I think part of the conversation that came up in Berlin is that this is not really used for return to play. That's not what it was designed for. And a lot of people are using it as an assessment tool to return to play. But questions like orientation, Glasgow-Coma scale, things of that nature aren't really useful when somebody no longer has symptoms. They've passed all their other cognitive tests. They're symptom-free with exacerbation. Now, it's a good check if you want to cover yourself. From a liability perspective, it's probably a good thing to do. But physiologically, it doesn't make a whole lot of sense to use this on the return to place environment. I think it's more apt to be used in the initial care, recognition, removal. We also have, as I mentioned, neurocognitive tests. This is the impact test. I think most of us are probably familiar with it. It's the most widespread and commonly used test. That's why I show it. I'm not going to talk anything about it. I'll stay away because that's not really my area, but I want to make people aware that is a objective test, an objective measure of neurocognitive function. We have the balanced error scoring system, which again is something that a lot of people use because it's pragmatic, it's easy to use, it's feasible, it's low cost, and it has some demonstrated efficacy. And then the final thing is the idea. I've talked a lot about vision. I'll talk about convergence and sufficiency in a little bit, but the King-Devick test is another thing that a lot of people really have gotten a lot of use out of. Again, it's on the low cost-ish side, depending on your environment, and it does possess some evidence to back up or support its use for removal from concussion or from play after concussion. The other piece is the VOMS, the vestibular motor screening. I think what has happened with that, and this is an opinion piece, and then I'll move on to some other things, is the athletic training community especially saw this paper come out from the University of Pittsburgh, and it was a great way that you can assess a new system, you can get objective numbers, you can provoke symptoms, and remove from play. And I think that in and of itself is worthy of use because there is some evidence to support it. But I would caution relying too much on it. I think, again, the basis for it is strong. I think that there are certain parts of it that can be improved, and I'll show some parts from it a little bit later. But again, I think that as athletic trainers, a lot of times we see a test that comes out that 60, 70 people with concussion in a study, and it's free, it's easy to use, I'm going to use it. But again, thinking through why we're using these things and what the physiologic ramifications are of a failed test, so to speak, are important things to consider when using any new test, especially in its infancy. And I think you'll see this VOMS will be revised over time, and we're conducting some studies right now that have kind of tweaked it a little bit, and I think over the next few years we're going to hone in on something that's a lot more useful for you as athletic trainers. So let's move on to postural instability, which is I'm like 20 minutes in and I barely talked about that. I apologize. I'm easily distracted and excited by a lot of things. So postural instability, we see that this is very common after concussion. It may result from some sort of sensory integration deficit. That's kind of the standard textbook answer to it. I think that it's multiple systems that are affected by concussion, as I said, and your ability to control yourself relative to gravity is actually a pretty amazing process. Bipedal motion is quite difficult. You think about how long it takes you to learn to walk and to stand in infancy. Again, you compare to kind of the animal kingdom, it takes humans a lot longer relatively than a lot of the animal counterparts to be able to move in the way that's natural as an adult. And dysfunction to that may result from some sort of sensory integration deficit where we're not able to use incoming information, integrate that, and output that to our muscles to fully stabilize ourselves and prevent ourselves from falling over. So how do we test this? Well, using the balance error scoring system, which as we've all seen, there's 6 different positions and 2 different conditions, both firm and foam conditions. We see that, again, I'll go back here, within 5 days post-injury, if you compare to baseline, most people recover on this. And so I think that the best is probably a good best practice to use. However, there are some limitations to it. And again, from my experience, and I'm doing more research than clinical care, I see a lot of overt dysfunction using this after concussion. But I also test a lot of healthy athletes that have not had a concussion, and it would also appear that there's some overt dysfunction there. I'll get into why that is in a second. The other part of the SCAT-3 that was briefly mentioned was the tandem gait test. And this is a way to assess dynamic stability within a clinically feasible test paradigm. So you have somebody walking on a piece of tape, 3 meters long in a heel-to-toe fashion as fast as they can. And we'll talk more about that in the next section here. So let's kind of transition here into how can we use innovative technology or objectivity, even if it's not technology, to improve how we assess gait and posture, right? So one of the limitations to gait assessments especially is how do you assess that in a clinic, right? The tandem gait test is probably the closest that we're getting because there's a timed element to that. But if I was just to ask you to walk down and back and I was going to visually observe something, that becomes very difficult to say yes, no, they're okay, they're not okay, just based on a visual examination. So again, deficits can be subtle or they can be overt. So this is I'm not against football. They just provide, because of the HD and the position of the cameras, they provide some really good videos that demonstrate concussion. So again, this quarterback got hit, and unfortunately, there appears to be a pretty overt deficit. He's having some trouble just being able to stand up. Now, there are other things that can contribute to that, but if there was a head impact and there's this display of not being able to get up with a teammate and their assistance, one might suspect that there would be a concussion. Now, deficits can also be very subtle, and with the changes in the NFL, now refs can remove, or there can be a call from the booth that somebody needs to come out. And this is a video of the Buffalo Bills quarterback coming out, and you tell me, does he have a concussion or does he not? Is he displaying the characteristics of gait instability or not? The refs certainly think so, and you could probably make a case that maybe there's an emotional disturbance, maybe he's getting mad, maybe he's like that anyway. Again, athletic trainers are uniquely positioned to assess that element, which I think is something that I try to stress, especially when in the room with physicians, physical therapists, things like that, that are perhaps more on the, this is, anybody can treat this. Athletic trainers are there, they know the people, and that's why they are uniquely positioned to address this issue. So, postural control tests. What are the limitations? So, with what we have right now, the balance error scoring system, clinician interpretation. So if Christine got up and did the best test for us, and Tom and I both rated her independently, we might agree or we might not. The inter-rater reliability is moderate to acceptable, depending on the study that you look at. I would say the overall body of literature suggests that it's moderately acceptable. But even more than that, distinguishing normal test variability. So even if we all agreed on what a best score was, what does that truly represent? So test variability meaning when a healthy person takes this 2 or 3 times in a row, how stable are those measurements? And you compare that to when a concussed person takes it 2 or 3 times in a row. Are the changes that we're seeing after concussion across time due to test learning, or are they due to recovery from the concussion, the physiologic disturbance of concussion? Now, how often are any of you going to stand with your eyes closed on one foot in a position like this, right? That's something that is a learned skill. And so somebody that does this over and over and over again, maybe somebody that has 4 or 5 concussions, might actually overcome that deficit a lot sooner because it's a learned characteristic than somebody that has their first concussion. And this is part of the inherent difficulty with assessing gait and balance after concussion. And again, a lot of the work that Tom's done and others have investigated some of the environmental aspects. So if you test somebody on the sideline versus test somebody in the locker room, you test somebody before season, after season, there are wild changes on the best. These are some of the limitations. I'm not saying don't use it. I'm just saying if being used, recognize the limitations of the tool. And there's some groups, our group included, that have tried to assess ways to objectively measure the best. So there's some accelerometers here. This study actually showed really no changes between concussed and controls using an accelerometer around the waist. This study put accelerometers pretty much all over the body and looked at the agreement between the rating and the output from the accelerometers. And the interesting part about this study here is a group in British Columbia. What they found was that none of the accelerometers out here really mattered. The only one that truly dictated performance was the one right here. And they didn't say this in the paper, but in discussing with some of the co-authors, the theory that they're kind of working on is, what is the controller of your vestibular system? Well, it's right here. What does it want to do? It wants to maintain stability. Because if it's going like this, you're going to get dizzy and throw up really fast, right? So this is probably one of our key indicators. If you can maintain your stability right here and maintain movement, or reduce movement, excuse me, you're probably going to be better off even if you're doing all this out here. That doesn't really matter. And then this is another kind of commercially available product that we were using at the McKellie Center that is a quick, easy output. It's another one of those ways to just objectively assess how people are maintaining their stability. It's kind of this integrated kinematic kinetic analysis. So let's transition on to gait. So we've talked about posture. So posture, again, is your ability to maintain your body position relative to the vector of gravity, right? So you're trying to stand in a way that is straight up and down. Gait really assesses dynamic balance control. So as you're walking, again, locomotion is a complex physiologic process. Not only do you have to look at where you're stepping to avoid some sort of slippery surface, hole, stick in the ground, things like that, but you have to integrate the sensory information coming in. I'll kind of demonstrate. I don't want to get too far out of the. Oh yeah, do we have a question? Yeah. Oh, I'm sorry, on the forehead. The accelerometer on the forehead was the most predictive of best performance. Does that answer it? Yeah. Okay, thank you. Please ask questions. Yes, that's good. So on gait, not only are you're putting one foot on the ground, right, and information's coming in, but then you have to control all of these muscles to move this way as this foot is lifting up off the ground. You're alternating between 2 feet and 1 foot on the ground. And your base of support, meaning the area underneath you that your body has to stand over, is changing with every single second. And so as you walk, you're constantly integrating information and outputting that to your muscles to stabilize yourself so that you don't fall over. And this is why we see a lot of what we know from the gait literature comes from the aging literature, where as you age, people that are at risk of falling, and for example, falling and fracturing your hip when you're 85 is a very poor outcome from that event. And those who are at risk of falling are less able to maintain dynamic stability as they walk. So transitioning into the concussion literature, we see that detectable gait deficits persist after symptom resolution using, again, instrumented objective measures. So we're going to kind of start in the laboratory system. or the laboratory setting, and we're going to kind of transition into more clinical outcomes. So bear with me if you're not interested in lab research, but I think there's some interesting things we can learn from that. So in children, so I think 16 and under, those who, they're 43 days out from their concussion, matched with controls, those who came in and just walked had to, or had higher stride width, meaning they had to increase their base of support to a greater degree so that they didn't fall over. And a lot of this isn't voluntarily conscious. This is just the behaviors that they are demonstrating. Similarly, some of the work from Tom and his grad students subsequently have showed that another complex process is stopping walking, right? So you've got all of this momentum moving forward, and to reduce your acceleration to stop, again, is not a simple thing. We take it for granted, but it is a learned characteristic that's fairly automated by the time we reach adulthood. But after a concussion, despite symptom resolution, again, there's a common theme here, so your symptoms have gotten all better, but you are unable to terminate gait to the same degree as a control. And then also, we see that elite athletes show locomotor deficits, dual task locomotor deficits, which I'll explain in a second, despite full clinical recovery. So that's not only symptoms, that's also impact and best, 37 days post-injury on average. So what is this saying? This is saying across the age spectrum, multiple studies, this isn't one study that looked prospectively, but multiple studies, gait is affected after concussion pretty consistently. And here's a good example of what I like to call a dual task deficit. So when we're walking, oftentimes we're not focusing just on walking. We're focusing on two things. And I'm going to go to the overt deficit again. So number 2 here, he gets hit. And he has 2 tasks to accomplish. Number 1, run off the field successfully. That's binary. Yes, no, does he do that? I think you can see the result. He fails that. But at the same time, there's a cognitive component, right? He wants to run to his medical personnel if he knows that he's injured. He wants to run to his sideline, and you can't really tell it here. He's actually running toward the wrong sideline. So he was unable to recognize his team from the other team, integrate that information, and run there. And I realize they're both red, but I do think that there was a cognitive deficit there. And gait is not only necessary in sport, it's necessary in everyday life. And these disturbances that we're seeing may be reflective of several underlying physiological phenomena. So not a single thing, but again, using the entirety of your brain network to execute a task during gait, it requires a lot of effort, whether or not you realize it. And the nice part is that most of us, and you can make a case for what age this happens based on how old your kids are or your nieces or whatever, by age 3, 4, 5, somewhere in that range, you've developed an automated gait process where you're walking, you've developed your gait pattern that will change as you go through puberty, as you grow, but essentially that underlying process in your brain network has already been established that early. So it's a very learned process, and it's something that we do every day. And because of that, it's likely that it's easier to detect some sort of deficit that is truly responsible or results from a physiologic event, being the concussion. So let's go into the lab and see what that looks like. So this is a healthy 14-year-old boy who we're asking to walk in a straight line, or just walk normally, I guess. There's a little bit of a runway, maybe a meter wide, where we say, okay, I'm going to ask you to do 2 things at once. I want you to divide your attention across 2 things. We have a motor component, which is just walk normally, and we have a cognitive component, which is walk and subtract numbers. So subtract by 7s from 100, or spell the word blade backwards, or say the months in reverse order, some sort of distractor task. And the theory for that is you want to divide your attention across 2 domains. And we think that after concussion, there is a reduction in your ability to allocate attention across 2 different domains, both motor and cognitive. And when isolated, just looking at maybe just gait, you might not be able to detect things from the same degree as when you add some sort of cognitive perturbation to that. And so again, this is healthy, kind of, you see he's walking and has a very tight control of what we call the center of mass. So as it pans around here, I'll kind of show you what I'm talking about, where he's walking and walking over the force plates and giving us good data and all that kind of stuff. But this is kind of what we think of as our center of mass. We want the mathematical sum of all of the body movements put into one place. And that's a representative of dynamic stability. And as he walks, you see very little movement from side to side. Now let's compare that with a 14-year-old boy who is 2 days out from concussions, within 48 hours. And as he walks, he crosses a photocell that makes a noise, just a beep. And what he has to do as he's walking is, again, subtract a number. But what you see is this incredible destabilization of his gait. And again, if you look kind of in this area, at this marker right here, you see it moving a lot from side to side. And a lot of people that see this say like, oh man, he looks like he's drunk, right? I promise that he wasn't. But it is that same kind of altered gait where you can't adequately control or output the information to your muscles to be able to control that side-to-side movement. And that's the result. It's not conscious. It's not something that he was trying to do, but he just couldn't allocate his attention to two different things to be able to execute this, what I would call a very simplistic task, again, if you compare that to the control. Now, looking at two examples is probably good, but I am a scientist, so I like data. This is, I'll orient you to the graph. This is a timeline across the injury. And what we see is that within 72 hours, excuse me, let me orient you first. The x-axis is time. So this is within 72 hours, 1 week, 2 weeks, a month, 2 months post-concussion. And we tested people across time with a concussion in red and matched controls in blue. The higher the y-axis is, indicates more movement from side to side, which would indicate worse dynamic stability. And what we see is that in that dual task condition, where individuals are asked to walk and think at the same time, they demonstrate more side-to-side movement from the time of injury and consistently throughout the 2 months post-injury, relative to their own single task performance. So if you look at so they're just walking, you see some good recovery, and again, it comes down to near control levels. But when you add a single cognitive perturbation, you see measurable and observable deficits consistently throughout the following 2 months post-injury. And you do that relative to controls that are in that dual task condition as well, and you see a little bit of variability, but really not to the degree of dysfunction that those with concussion have. So 2 questions for you that I want you to, again, think about is number one, what is a change of a 1 centimeter of center mass sway actually telling us? Right? So I'm going to pick on my own work. What does that mean? 1 centimeter? And does this mean that all high school athletes should stay out for 2 months after the injury because we found deficits? You don't have to answer out loud. You can just think to yourself. All right. So here's what I came up with. See if that aligns with what you're saying. As a background, sport specifically is requiring attentional allocation. Again, this slide board here is another good example of where you have people moving in multiple directions, doing sport-specific movements, and they're moving in this plane and that plane. But then you also add an attentional component to it, right? And you ask them as they're sliding to also catch a ball or respond to some sort of numbers that you're holding up. Tell me how many numbers am I holding up, so that they're having to look at you and move at the same time. I think that these are more kind of and 3X, they're not paying me any money to say that, but I think that I promise that this is the first time I've ever seen this, but I think it's a good functional way. Any sort of way that you can move and think at the same time is going to be a good way to assess whether or not somebody's ready to go back after a concussion. Now, the relatively small differences. So on average, about 4.6 centimeters of center mass sway versus 3.6. First of all, that's like a 20% increase. So that actually is significant, I would say, given the variability from one testing session to the next. But if you add a single cognitive perturbation, and that can destabilize your gait, what about on the field? Not only are you having to think about the months backwards, which is a bit arbitrary, but it gets at the same point, you're having to think about your position, the other person's position, the opponent as they're coming at you, navigating that field to steal the soccer ball, basketball, make a tackle in football, whatever it is, and being able to effectively protect yourself while you do that. If you have a slight deficit, perhaps you're more likely to sprain your ankle, or you're more likely to get hit in the head where you're not protecting yourself to the degree that is necessary to reduce your risk of concussion. And so I guess I will transition here from this is very restricted to the laboratory setting, but what about common athletic training settings? So again, this is where I conducted my dissertation research. This is a giant lab. There's probably $300,000 worth of equipment there. We've got all the space in the world. It's like, you know, we have people run track laps in there. It's about a 50-meter track. So this is not common, I recognize, in most athletic training settings. So how do we get that into a hallway? So right now where I'm collecting data, the physician goes into the exam room with a patient. I set up some very simple equipment right outside and have them walk and talk for me in these hallways. And these are actually the places where I'm collecting data. And what we're using is a series of commercially available accelerometers. So they're not $300,000 like the motion system. They are still like $6,000 or $7,000. So they're not cheap. That's more double probably than a lot of high school athletic training budgets. But it is, again, we're scaling down to something that is a bit more widespread use. And I don't have any data on it right now, but I'm also interested in, you know, how do we then scale that to something that everybody can use? Maybe there's something in our phone that we can evaluate. Our phones are really good at getting us information about movement using the accelerometer and gyroscope. So again, those are the things that we're working on, but ultimately we want to translate to practice. And I'll go through these pretty quick, but what we found thus far is that these dual task assessments outside of a lab, Tom and I collaborated, really found, number one, they're feasible to do. Again, given the equipment at a research institution, this is feasible to do in baseline testing situations. And our dual tasks may differ, our performance, whether you're a football player or a crew athlete, based on the nature of the sport. And we also found that concussions across the lifetime. So if you report with a second, third, fourth concussion, your dual task gait is worse off than a control. Whereas if you're coming for your first concussion, you're actually very similar to a control. So these are some of the things that we're able to find. We're also looking at what we call a dual task cost. So when you have to walk and think, you measure that change. How much change is happening between walking and thinking? Kind of establish your own baseline, and then you measure that change to when you have to do two things at once. And we see that females are actually worse off than males after concussion. So there may be a sex or a gender effect depending on how you're defining those. Yeah. No, I don't. This is very much an exploratory study. So a lot of the literature suggests that females have greater symptom reporting tendencies. They're more likely to endorse more symptoms. And so we don't have any measures of hormonal cycles or anything like that. That's the next part. We kind of wanted to see, is there a difference? And what we're currently establishing, hopefully, is a way to gather blood and get, you know, where females are at in the menstrual cycle compared to men, and see if there's some theories regarding neuroprotective or neurodetrimental effects based on the time of the month that a female gets concussion. So we'll see. That's very, very exploratory. Thank you. And again, dual task deficits persist after other symptoms are recovering. So again, nothing too revolutionary there. So let's transition now into a little bit even more pragmatic with the tandem gait test. So this again was a recommendation on the SCAT-3. We'll see if it's on the SCAT-4 or not. I think that it's a valuable test because it assesses a different process than the best, and it's a way to assess postural control. And these are the instructions, whether or not you've read them. Briefly, you walk along the line, you turn around, you come back as fast as you can in a heel-toe manner. If you fall, if you take longer than 14 seconds, you don't count that as a trial. But again, we're assessing dynamic stability or dynamic locomotion here. And what the tandem gait has shown, and this is upcoming from Tom's group, Jesse Oldham's paper, is that it is unlike something like the impact test has shown a lot of these common determinants of performance like sex, concussion history, sport type, things like that, influence how individuals are performing. The tandem gait test, again, because it is a bit more objective than, for example, the best, but it also involves processes that are less influenced by some of these common comorbidities, may actually be a way to assess concussion in a more robust manner. Now, if we also take this, and this is a study that we have in review, and we look at the standard version of the tandem gait test, which would be single task, but you add a secondary task to it, we see that initial deficits, this is a very small pilot study, so I caution extreme limitations exist, namely that we only had 17 people in the study, 10 concussed, 7 controls. However, that being said, we found deficits within the first 72 hours of concussion when just using the standard form of the test. But when you add a secondary task to it, so you have them do this tandem gait test, again, while they're executing some sort of mental task, we see that there are differences at the first 3 time points, which are resolving somewhere between 2 weeks and a month, which is longer than the single task form. So again, the utility of dual tasks are that they're fairly easy to use. You can execute it with this test with a stopwatch and an answer sheet, where you might be able to detect deficits that last longer than if you just do a single task form of the test. All right, so I've got about 5-10 minutes left, and we'll move on to the last thing here, which is where are gait and postural evaluations now fitting into the multifaceted approach? So we've gone through kind of lab to clinic. How do these fit into our overall approach? I want to talk about 2 potential modifying factors and perhaps how they're affected by concussion. I talked about vision at the beginning, said I'd come back to it now. We see that oculomotor problems are probably present in anywhere from 30 to 65% of patients with concussion. I would probably lean on that higher end, just given kind of what I explained earlier. And we also see that the timing of return to physical activity, or cognitive activity, as Tom was talking about, and I won't step on his talk, but that this notion that when you return is probably going to affect your recovery, in addition to a lot of other factors. But the cornerstone of concussion management is physical and cognitive rest until symptoms resolve, right? I would venture to guess that that will no longer be the recommendation, given the most recent evidence. So around February, March, sometime whenever that next position statement comes out, I imagine this will be more liberal, where we're encouraging people more activity earlier on in their recovery. But again, visual physiology, we see that a lot of the brain is devoted to vision. It ranks among the highest energy consuming systems in the brain. If we go back to the neurometabolics of concussion, it's a mismatch between energy available and energy required to overcome the problem and restore homeostasis. That's the fundamental problem with concussion. It is an energy crisis. And if the visual system requires a lot of energy just to be able to withstand itself in a normal circumstance, after concussion, this is one of the most likely places that you're going to see some sort of a deficit. I already said this, so that's good. So one test that you can do is the near point of convergence test. I don't know how many people are familiar with it. Briefly, you get a tongue depressor, you tape an X, size 14 font, or an I, or some sort of accommodative target on the end of it. You have the individual, ideally you would do this, but or the individual can do it themselves, slowly move it until they report that they can no longer see one X, but it diverts into 2. You're also observing for kind of outward deviation of their eye, but the near point of convergence is typically defined as the patient-reported diplopia point. And that right there is anything over 5 centimeters from the tip of the nose to the target, or if you measure from the bridge of the nose, which would probably be a better measure because it reduces variability in nose size. That's probably 6 or 7 centimeters, depending on the place you look. But again, that is one part of concussion that may be affected, or one function that may be affected. And that may be associated with a lot of other deficits. So the concussion itself might recover, say, in 7 or 14 days, whatever you want to say. But this underlying problem that is a convergence issue, the kid goes back to class, a high school student, and they're looking down, they're taking notes, they're looking up at the board, they're looking down. If their eyes aren't working together to create that focused binocular vision, that in and of itself is going to cause a headache. And it's hard to distinguish now, was that the headache from the concussion, or is that a headache from the visual problem? And there are ways that we can potentially treat that. Now, how does that play into vision? Well, what we wanted to do was compare those who reported acutely following concussion to our clinic on some of these basic spatiotemporal gait measures, and again, in both single and dual task. And we found that those with a receded near point of convergence, so if they were unable to converge within 5 centimeters, also had reduced stride length, which probably played into their reduced average gait speed. So they weren't able to walk nearly as efficient, I would say, or they walked more conservatively than controls. Whereas the group that had normal near point of convergence, meaning they could converge very close, walked very similarly to, maybe not quite on average, but those 95% confidence intervals overlap quite a bit, that they were able to walk similarly to the controls. And just for reference, so those were the two parts that were associated. No changes in step rate or how much time they're spending with 2 feet on the ground. So it appears to be that they're reducing their stride length to allocate their attention in a proper manner. We look at the relationship, again, on a correlation scatter plot, and we see that as that near point of convergence gets further out, their gait speed slows down. This data point here was somebody that was very clearly severely impaired, so it's probably influencing it quite a bit, but I'd like to be in full disclosure to show everything. So a couple things, I got about 5 minutes, or how much time do I have left? Oh, okay, all right. I think I've hit the minimum at least. All right, okay, I'll try to wrap up here. I know that we've all got the Patriots game to get to, or the Seahawks if you're me. So patients that come in with convergence deficits are also displaying gait deficits, and these one-size-fits-all treatment approaches may actually be detrimental for some patients. And I think that's what we're seeing with this activity literature. We're grouping all patients together, and we're saying, on average, this group gets better than this group. But we're missing a lot of the nuance and subtlety that is the individual presentation of concussion. And these targeted treatments, meaning impaired convergence training, is one of the kind of, I would say, best approaches in those who have a concussion and convergence insufficiency. There are some documented ways that optometrists specifically can help to improve recovery after concussion. Hopefully we'll have some randomized control trials that help to establish that, and those are in the works right now. We're involved with a couple groups, and we're hoping that that'll be the next step. So again, how are we incorporating these objective assessments? It's going to depend on your setting. And then we get back to what Tom was talking about. And I think that he left on a really good point. I'm going to just discuss 2 studies real quick that investigate, so if we treat everybody differently, now how are we going to decide who goes back to play when, or even like how much physical activity? Can you exercise for 10, 20, 30 minutes a day? And what is the proper timing of that? So again, we're reconsidering this. And I want to talk about physical activity and concussion. So this is a study that we did in our clinic. The concussion occurs, people come in, they get assessed on average about 12 days post-injury, assessed on all these different measures: age, sex, symptoms, prior treatment of headaches, physical rest since their injury. We followed up at multiple time points until they were done with their clinical care. And we put it into a similar, this hazards ratio model, which we don't need to get too concerned about the methodology there. But really we found that 2 things predicted prolonged recovery. One, or just how long it was going to take them to recover. One being female sex and one being initial post-concussion symptom scale. So higher symptoms led to longer duration of symptoms. That's not shocking. But we did not find any association between initial rest and physical activity at each time point. We were assessing how much on a kind of that graduated 1 to 7 scale, where they were at, 1 being no activity at all, 7 being full go, full clearance to participation. We did find among adolescents, that the more physical activity they did, they actually had shorter symptom durations. But again, I would warrant caution, because while significant, this confidence interval is about as small as you can get with it still being significant. So it's about maybe a 0.1% more likely that they're going to have shorter symptom duration. So I think part of that is also, as you start feeling better, you're more likely to report that you've done more activity. So I don't think that this is causative or driving it in any nature. I just think it's an interesting observation. And then finally, we look at the risk of re-injury. So what about after people have resolved their symptoms? Well, we see that we have kind of neglected, we get them back to play in the literature, but what happens after that? And we see that 9 studies in the past 2 years have shown some sort of association between concussion and an increased risk of not another concussion, but another musculoskeletal injury. And could these lingering motor deficits be responsible for this? Perhaps. In brief, what we found was that prior to going back to play, in this period, again, these are the same subjects I showed kind of toward the beginning, individuals were getting better. So they were improving by about 10% as far as how they walked and talked at the same time, their dynamic stability. But after they went back to play, we saw a reverse effect where they started getting worse. And perhaps if we're letting people go back to play too early before the physiologic deficits have recovered after concussion, they might be more likely to have a processing speed issue, reaction time issue, a dual task or multitask issue where they're able to effectively protect themselves back out on the field of play. And you compare that to, didn't make it in, their symptoms really didn't show any change. So again, there may be some lingering motor deficits that we're not detecting at a clinical level that predispose individuals to another injury. So let's talk briefly about clinical implications, that these objective and instrumented tests are probably going to provide a more sensitive method to identify recovery. And this is also a very hard thing to quantify, as Tom said. What is recovery? And this is kind of how we're approaching it, and we're hoping that this is going to be successful. And it's really unclear if the current tests can adequately identify functional deficits. So again, working on ways to use objective outcome measures in our clinic following concussion is going to be probably our best bet to truly classify recovery. So in conclusion, I'm still under an hour. 3 things from those original questions. Number 1, there's a lot of testing forms available. I only covered a couple. There's others outside of this, so I apologize if your favorite test wasn't covered today. But needing to balance that objectivity with the technical demands or the cost demands at your specific institution. I think that's an important piece to consider. Dynamic tests, in particular, when you stress the attentional system, are probably going to be more sensitive to prolonged deficits than your traditional clinical tests. And finally, I think, again, this is more of a research. I think as athletic trainers, you're dealing with people on an individual basis. So this might not apply as much, but I think from a research perspective, grouping all concussion patients together is probably going to reduce our ability to truly identify what's going on and how recovery is occurring in each individual person. So with that, that's it for me. Thank you so much. And if there are any questions, I'm more than happy to answer them, and we'll stick around afterwards. We'll go from there.
Touched on the multifaceted approach and how that might be changed with dual tasks. Do you think that they're going to start recommending dual tasks, like cost-effective pay assessment within the multifaceted recommendation?
Yeah, so the question was, can we assess dual task deficits or some sort of dual task component within the multifaceted evaluation of concussion? I think that we can. Tom and I are both working on ways to be able to do this. But again, the challenge is a lot of these things that we're assessing don't have a reliable outcome measure to this point. And again, I think that we're working on ways to do that. Some simple things that you can do to try to stress the system, so to speak, in a clinic is combine elements from a vision and a balance task. So the best is a good example of that, where you remove vision and you have their eyes open and you look at the changes, right? That's not necessarily a dual task, but you're altering the different conditions. And so I think for us is, as you're evaluating people, can you add in something that is going to stress the system a little bit more and perhaps identify some sort of functional deficit? Yeah.
If you know if the eye-sync goggles are valid and reliable.
Do I know if the eye-sync goggles are valid and reliable? Are those the ones? No. I don't know anything about them other than I don't know anything about them. I'll stop there. So I don't know. I don't know of a whole lot of literature. What I can say about test psychometrics is that we need to be very careful about using tests that don't have the necessary validation. So reliability, minimal detectable change, and that goes into test validity. And so I would be wary of commercially available products that don't have a long line of literature to back them up. And if that's it, that's it. Thank you all so much for sticking through.